Thank you. So combining this sit-on placement with the minimally invasive technique, this is a novel technique which we have described and which we thought is possible. What was happening was in lot of conferences we made our foreign faculty or faculty who was trained in minimally invasive techniques do these techniques, and this internal opening management is the Achilles heel of all the minimally invasive technique. So whatever they were doing, many of those patients were recurring, but we knew that we being in private practice, we have to offer some minimally invasive techniques to the patient, because many of these patients want that minimally invasive technique because they have undergone ischiorectal abscess drainage and they have seen the pain which they have to undergo and the dressing. So they are not very, their mind is not tuned to the open conventional techniques, and they require the minimally invasive option. We always tell our patients that first thing is to prevent recurrence, second thing is minimally invasive. It is not the other way around, and sometime if it is not possible, we will have to convert, and that is for your benefit, and most of them time they agree to this point. But if you do not have those techniques in your armamentarium, like a VAAFT or sometimes some people are doing laser or whatever, and you tell the disadvantages of VAAFT or laser, then these patients will not come to it. They will go and get operated by some other. So you should have everything in your armamentarium and then offer the patient whatever is the best for the patient. That is most important. So till now also, traditionally fistulectomy are still the gold standard with well documented success rate, but particularly effective for simple fistula. But in these procedures, they have higher post-operative pain, they have painful dressings and wound care, longer healing time, more perianal trauma, and if we are cutting, then increased chances of incontinence is also there. So there are various options which are there, minimally invasive. One is a VAAFT, which I will be talking. Then there is laser closure, FILAC. Then lift procedure, which has been talked. Then there is fibrin glue and anal fistula plug, which is not much done. Now endoscopists are also coming in this picture, and they are doing over a scope. Clips are being applied, which is also not very useful. And then modified lift plus techniques that lift with some other materials are being used. So I will just be talking about VAAFT. So this is a procedure which was described by Munir et al. In 2011, and there is a lot of documentation, and this was the first paper which was described. And the main advantage which is there in VAAFT vis-a-vis other procedure is ability to view the fistula from the inside and eradicate under the vision. So you can identify the tract, you can identify the secondary tracts, you can identify the abscess cavity, then you can identify the internal opening through direct vision or through other techniques, and then treat this patient. And we all know failure to identify the internal opening or its branches is the main cause of recurrence of fistula. So very important thing in all the fistulas which everyone will tell is good clinical examination. You should take care, good history. Patient might be saying that once there was one discharge was coming from one side, then it started from other side, the other side might be partially healed. So you should always examine it well, that it's one side, both side. Then you should see the external opening where it is, then do a PR, and where you will definitely feel, clinically is very important, you will feel some enduration, or patient will feel some pain because there is some inflammation where the internal opening would be. So you should do it clinically, and most of the time if you are able to feel the clinically internal opening and you can see the external opening, half of the battle is won. Because you know where the direction would be, you would understand this. The other things are complementary. Most important is clinical examination. Investigations are secondary only. So then comes the investigation. In minimally invasive technique, it is better to do the MRI of these patients, because initially when we are doing VAAFT, we are not using methylene blue, we are using peroxide, so we cannot stain that tract because then it will get all stained. So we generally get an MRI done and we get this picture. So it acts as a roadmap for us, where this internal opening is, where is external opening, from where it is going. So most important is you have to sit with the radiologist and plan the procedure. Don't think that you have got the report, then that is the end of it. You might tell the radiologist some things like we are seeing something at the other side also. It's a horseshoe shaped fistula might be there. So you should always discuss with the radiologist and try to make this diagram with the help of the radiologist, which will act as a roadmap for you. So these are few, this was this one patient which we did. So beautifully the radiologist has told where is the cavity. It's piercing at 3 o'clock. Then it is going intersphincteric. Then it is going into the internal opening is at 6 o'clock. So it is so well documented, so well defined. So when you do this procedure during the surgery, it's like a GPS only for you. You are just following that path. It will become very easy for you. So just what are the scope, what are the instruments which are there? So this is a fistula scope. This is a 8-degree scope which is there. It has a handle. Then we have a 3 mm forceps. Then we have an endo brush. Then we have a cautery. Then you require a cut endoscope to see the internal opening. Then you can scoop it also. And if you are closing it with the help of a stapler, then you require a stapler also. So this is the obturator through which we do the diagnostic scopy. And then the coagulation where we coagulate this. This is a blunt point tip is there, and it is very good. It is very flexible. It can go into the curved direction, as you will see, and we show the surgery when we are doing it today in the afternoon. So this is a very flexible, good scope, and it has a handle, so you can manipulate it well. And this handle can get detached also if you want, so that you increase the length of the scope if it's a longer length. Then there is a one optical channel, then there is one irrigation channel, and then there is one working channel. So these three are there, so which we will be showing you when we are operating. So it is done with the help of glycine and mannitol. This is it has two phases, diagnostic and operative phase. So glycine with mannitol, what this is, it decreases the edema post-operatively, which will be there. And glycine, you can use a cautery because of this. So this is very important to use both ways. Sometimes our technician forgot to use mannitol and did not put it. Then post-operatively, patient might have some edema or discomfort also. So first step is visualizing the fistula tract through the scope. So you will just see this. Here we can see there are two, one is a blind track and the other is a track which is going into the internal opening. So this will be reddish color scope because it will have inflammatory granulation tissue. If you're going into the false track, it will be more brownish whitish color. So you can identify and you can see that this is inflammation is there, red tissue is there, and two tracks are there. One is Y-shaped type of thing, one is going internally and one is ending blindly. So this can be done easily with the help of the fistuloscope which we have. Then is confirming the internal opening. So this is the thing which can be done when you are doing irrigation and doing diagnostic. You might see a fluid coming from the internal opening. Sometimes there is mucus plug. If you put pressure, then from there it can come. So that is first. Second, you can see a translumination. The tissue getting thicker, thinner, and you can see translumination where you will see that there is the internal opening. The third is what we do. We mix the saline and the peroxide, and with the help of the infant feeding, you will just see, with the help of infant feeding, 6 French, cut it at the tip, and then we you will see the peroxide coming from here. So this act as a guide, and you have already got the MRI, you know where the tract is. So we do the technique in little different way. So first we will just show you what is the we do and then what are the techniques. So now we have done the internal opening is there. We see the tract. Now we have to coagulate the tract till the level of the sphincters which are there. So now we use a blunt point cautery, and then over this cautery circumferentially 1 mm by 1 mm over all the 360 degree. You cauterize this with this cautery, blunt tip cautery. So the laser vis-a-vis cautery, you have to do this 360 degree. In laser, when you are doing it, because it gets 360 automatically, so that factor is not there, but you cannot use this laser with the VAAFT because that scope is not compatible. You have to use it then blindly. So then slowly with patience, very important in any endoscopic procedure is patience, because you require vision. If you have bleeding, if you go into false track, everything will get swelling will be there. You will not be able to do anything. By patience, slowly and slowly you do all the 360 degree and try to come slowly 1 mm behind, 1 mm behind, 1 mm behind. Then ultimately you will come at the level of the external opening. So this is way which we are doing, and this is the handle which is there. So by this you are able to coagulate, so that red will become white now. So that will become white, and then after this what white it has become, you can use a brush and you can cauterize, you can do the curating, or you can, if it's not very long, you can use a scoop also to do this curating thing. We can send this curating to biopsy for biopsy also, which we have started doing. In one of the patient, we got a tuberculosis, a biopsy positive for that patient. So you can send that for biopsy also. So this is the main thing which I want to highlight on managing the internal opening. So what was happening was, this is the main Achilles heel of VAAFT or any minimally invasive technique. So there are various techniques of doing it. You can use a suture closure, fisheye closure, you can use staplers, then you can use mucosal advancement flaps, and you can use other mesh also at that area. What we have been doing is, we are combining that, we are cauterizing that track by minimally invasive, and this internal opening, what Dr. Pawan Lal is saying, we use a cutting silk sit-on, and we take a right angle, and we know where the track is from the internal opening. We take that forceps and come into that external sphincteric space, which sir was also saying, make external incision there. So we are doing this, just you will see this. So by this, what we do is, most of the time by 4 weeks, it gets removed on its own, sit-on gets removed, and then it heals by the granulation tissue. If it does not get cut by 4 weeks, then we cut this at 4 weeks most of the time, and it is getting managed well, and it is healing from inside. Main thing is the intersphincteric space where the inflammation is. We are taking care of that along with this. If we are just suture closuring it, we were not very comfortable, and we were not able to market it well, and we were not ourselves convinced, because we were seeing a lot of recurrences. So there are some disadvantages of this procedure, because we are ultimately it might be cutting this sphincter. So that is a disadvantage. But till now we have been doing it for 2.5 years. We have not seen incontinence. Most of our patients are doing well, and they are happy with the procedure, and they are comfortable. So the other is a suture closure of this internal opening. You can take 2 sutures, you can take a fisheye suture. There's various methods are there of closing it, and many methods are there. Whatever one is comfortable, one can use this to close this internal opening. But we are not doing this technique. The other is a linear stapler technique. You take internal opening, and then you fire a stapler, but because sometimes there is a lot of fibrosis is there at the internal opening, you might not be able to lift this, and so we have not been doing it, and we have not practiced this technique till now. So the other is a mucosal advancement. You can close the internal opening by mucosal advancement. You can combine the lift with VAAFT, or you can use these bioabsorbable meshes which are there, or glue are there. So, but what are the limitations? As we told, the closure of internal opening is a weakness. It is not suitable for simple fistula, because you will not give much advantage. It's a rigid fistuloscope which limits the maneuverability. Potential for false track creation is always there. We should always be careful. If it's a very thick fibrous track, you might not be able to obliterate the whole of the cavity, and it requires a longer learning curve. So then it's not indicated in simple fistula, extensive perineal sepsis, narrow fibrotic fistula tract, scarred internal opening, and patients who have sphincter dysfunction, you have to repair that sphincter. So you should not do those in this. So there's a lot of literature. This was done by Munro et al. And others. They did a meta-analysis. This was done in I think 2017. So it shows good results. Then this is the latest which is there in 2022, and success rate of 83% is there. Recurrence rate is 16%. Then they compared how were they able to identify the internal opening. They say it was able to identify in 97%. Based on the recurrence, what technique they used. So that is almost same. Advancement flags, stapler sutures, almost same recurrence is there. So thank you.
Most of the curves, fistula tracks are curved.
Yeah.
So, and it is straight fistuloscope. So, do you have any take on?
So, because it is angled, na, and what you have to see from where it is coming and where it is turning. So, where it is turning, so we are placing sit-on there. Then it becomes a straight track most of the time. You will see this, whatever today we are doing, if it's possible, we are able to identify the internal opening. So, it is opening at 3 o'clock. Internal opening is at 6 o'clock. So, it is a curved track. So that curve is we are navigating with the help of sit-on. and then we are doing that area with the cautery, and then it is maneuverability is there. You can place internally finger, you can stretch it, it can become little straight also. It is not that some curve will not be able to manage, but sometime you will not be able to manage, and you might have to convert these procedures to other procedures based on what is there. Lift is one of the very good technique which I feel which we should do, which we are not doing, which will give good result in these patients.
Thank you.
Can I add something?
Sir, where is sir? Sir.
Curved tracts is a theoretical problem, not a practical one. If you wait and let the tracts get dilated, the tracts will become dilated. Wait 5 minutes. Any curvature can be negotiated because the skin is soft and the tissues are soft. You have to just wait, and when you go forwards, keep the scope in the center. The tract will dilate and it will easy go. Theoretically, curved tract में कैसे जाएगा? It's a straight scope. नहीं, तो I'm saying you wait. You wait 5 minutes. I've been doing it since last 14 years. So you have to wait for that time. Once you wait, the tract dilates and then it can go. You go to the point where you think it's curving, wait. Wait for the tract to dilate. You need some pressure on the fluid and you will have the tract. And Tarun, I did single closure, double closure in 2 layers. I did fisheye, which I had designed. Everything fails.
Yes, sir.
The only thing which is actually working, as you mentioned, take out the internal opening separately. Then you can do VAAFT.
Yes, sir. Yes, sir. Yes, sir.
Excise the central opening, you've done it.
Yes, sir. Thank you, sir.
Tarun, hello.
Yes, sir.
Tarun. If you have a problem, as the Dr. Kushal has told you, it's true, almost true, every case. But if still you have a problem, you can use the technique used by urologists. You can have a pathfinder and you can have a small wire, the thermoguide wire. The thermoguide wire goes very beautifully inside the tract with the pathfinder, if at all you have any problem. Or even your Bugby electrode, you can slowly forward it and you can negotiate your probe, this fistuloscope over that. So there's not much a problem of, or if at all, still you have a problem, as you do in a thyroglossal cyst, you divide that into 3 compartments, 2 compartments, you can always do that. So it's not a problem. You can negotiate that.
Sir,
It's dealing only with the one track, or is there branching tracks?
branching also you can do, sir, because see, you see there was V shape was there, so you cauterize that, you cauterize this, and ultimately you are managing that intersphincteric space with internal opening where this main source is. That is getting curated or that is getting fibrosed ultimately. So then everything heals.
Another question is, if you are cauterizing the track, still you need a set out for it?
We are managing sit-on only for the internal opening and intersphincteric space. We are not using, if there is abscess, ischiorectal, then we use a draining, the nylon or the pink color, the color tubes for draining that area, and that we remove after 4 to 6 weeks in the OPD only. For the cavity to collapse.
Internal opening you are closing. There was recently
So internal opening we are not closing. So that is what I say. Internal opening we are always placing a sit-on there.
sit-on.
Always a sit-on. Thank you.